Hello everyone, welcome back to my YouTube channel Speedy Dentistry. Today we'll be learning about midface fracture. So midface is basically the segment from front to zygomatic suture till the alveolar bone of the maxilla, and for dentate patient it is till the incisal edge. This is for edentulous, that is till the alveolar process of maxillar bone, and incisal edge for the dentate patient. And midface has been compared to that of a matchbox because of its fragile nature. The upper skull has been compared to helmet, and the lower mandible has been compared to hockey stick. Rowe and William first classified the midface fracture. This is not maxillary fracture classification, that is midface. So for the midface, it could be central or lateral. For the central, when the occlusion is involved, it can be dento-alveolar fracture or Leaford 1, 2 or Leaford 3 fracture. Alright. When the occlusion is not involved, can be frontal process of maxilla fracture, or it can be nasal bone fracture, lacrimal bone fracture, or the ethmoid bone fracture. And fifth one is for the combination from above, that is from 1 to 4. Also, they classified the lateral for the zygomatic bone fracture, zygomatic arch fracture, and orbital fracture. For orbital, they classified it as blowout fracture or blow-in fracture. Also, for the blowout fracture, it could be pure or impure, which is already described well in my orbital fracture video. Now coming to the Rene-Leeford classification. Rene-Leeford in 1902, what they did, they carried out the study on cadavers where low energy force was applied and it was unidirectional. For the Leeford 1, the force is at the level of maxillary teeth. For the Leeford 2, it is at the nasal level, and Leeford 3, the orbital level. So other names for Leeford 1 are low level fracture. So Leeford 2 will be middle level. Also, it is also known as subzygomatic or horizontal or transverse. Subzygomatic because it is below the zygoma, horizontal and transverse because of the fracture line. Pterygomaxillary disjunction will be there. Telescopic when both the fracture segments move towards each other rather than moving apart. Gurin's fracture, which is hematoma at the junction of hard palate and soft palate. Also, the Leeford 1 has been described as a floating, like a floating balloon, the floating maxilla, when it is bilateral Leeford 1. For the Leeford 2, it is mid-level or pyramidal because of the fracture line, and pyramid is also when the fracture is bilateral. Now coming to Leeford 3, which is basically craniofacial disjunction. For the fracture line, Leeford 1 we know the low level or horizontal, Leeford 2 the pyramidal, and Leeford 3 will be craniofacial disjunction. So this is Leeford 1, Leeford 2 and Leeford 3. And if this is pterygoid plate, that will be behind basically. It will be at lower 1/3, middle 1/3 and upper 1/3 of pterygoid plates. For the Leeford 1, the specific fracture line will start from the lateral process of pyriform aperture, and if this is maxillary sinus, it will run below maxillary sinus but above the roots of maxillary canine, and then moving backwardly it will fracture the pterygoid plates at the lower 1/3, and this is the lateral line. And medial line will be there, in which it will run through the lateral of the nasal bone from inside, and then nasal septum at lower 1/3 will be fractured, and for moving behind it will fracture the pterygoid plate at lower 1/3. For the Leeford 2, the fracture line starts from the nasal bone, and from the nasal bone covering the frontomaxillary process, and if this is lacrimal sac and this is infraorbital foramen, so this fracture line moving behind the lacrimal sac may or may not involve the infraorbital foramen, and then this is maxillary sinus, it will be moving towards the anterolateral wall of maxillary sinus. So this line formed will be shape of a pyramid, and the pterygoid plate will be fractured at middle 1/3. Coming to the Leeford 3 fracture line, it will start from the frontonasal process, then the frontomaxillary process, lacrimal bone will be affected, ethmoid bone will be affected, and this is optic foramen. It will run behind to fracture the sphenozygomatic. Also in this is the zygomatic arch that will be affected, and one line will be running behind the infraorbital foramen, and this is zygomatic arch. This will be affected for both the sides. When both the sides, that is bilateral, there will be craniofacial disjunction. For the clinical features, for the extraoral clinical features, some of the features are specific. For the Leafort 1, the specific feature will be upper lip swelling will be there, and also gross facial edema would be absent. That will be seen in Leafort 2 and 3, and pain and paresthesia will be at the level of maxilla. All right, that is obvious. And for the tooth, there will be cracked pot sound because of the fracture at maxillary tooth level, and also there will be Gurin sign, palatal split will be seen. These are some specific to Leafort 1. For the Leafort 2, panda facies will be seen because of the gross facial edema, and telescopic, this will be a dish face deformity because of the flattening of midface. And for the eye, there will be diplopia, subconjunctival hemorrhage. Subconjunctival hemorrhage will be flame, representing a flame because of the bright red color. Bright red color will be there because conjunctiva is paper thin. All right, so this is paper thin, and extravasated RBC will get all the oxygen, so it will be bright red in color. Also, when the subconjunctival plane shifts to the subcutaneous plane, there will be circumorbital ecchymosis will be seen. For the specific Leafort 2 and 3, will show panda facies, and also raccoon eye will be seen. Raccoon eyes will be seen. And CSF leak from the nose, that is CSF rhinorrhea, and CSF otorrhea will be seen. So what is basically CSF? It is leak of the brain fluid or the CSF to the nasal or auditory apparatus. So for CSF leak, how do we identify it? So first, rail track appearance will be seen. So blood will flow out first, and CSF will follow it, giving it a tract appearance that CSF is falling. Next, there will be ring sign. So we'll remove this ring. So there will be ring sign. This will be seen on the pillow of the patient is using pillow, and also on the blotting paper. So clear hello sign will be seen. Next, when the patient sneezes or wipe the fluid from his nose, so when there is nasal secretion, that will be making the cloth thick, while if it is CSF, no thickening will be seen. Also, the glucose content is more than 45 milligram per deciliter. This energy sign signifies the glucose. For the CSF, the glucose content is much higher. Coming to the taste perception, it will be salty, and for the labs, we'll go ahead with beta-2 transferrin or tau protein test. For the management of CSF leak, we go ahead with the antibiotic coverage for the patient, and also we make the patient in propped up position, and cranioplasties are done when there is no effect from the previous managements. For the management of Leafort fracture, specifically for Leafort 1, so basically we can go ahead with closed approach or the open approach. For the closed fracture management, we can do internal wire suspension, we can go ahead with suspension, or external POP head frames can be used, which can be used in all three. For the internal suspension, we can use pyriform fossa, infraorbital, zygomatic, circumzygomatic, and supraorbital for Leafort 1. While for Leafort 2, pyriform fossa is already involved, and infraorbital also we can't use. And for Leafort 3, the only approach we can use is supraorbital, which is intact. And for the ORF, for the Leafort 1, we know that the fracture line is here, so we use L plate at the pyriform aperture and at the zygomatic-maxillary buttress. For Leafort 2, we know the fracture line is like this. So here we'll plate a inverted Y plate Here we'll use an inverted Y plate. Here infraorbital plate will be used, and here we can use a straight plate, 4-hole or something like that, and we, or also if zygomatic maxillary buttress is affected, L plate is used. For the Lee-Ford 3 fracture, this is the approximate fracture line. So here again we'll use the Y plate, and laterally we'll fix the frontozygomatic suture commonly with 2-hole plate, and for zygomatic arch also we'll plate. Afterwards, the Lee-Ford only classified the Lee-Ford 1, 2 and 3. Marciani modified this classification and said for the Lee-Ford 1, when there is low maxillary fracture, it can also be multiple segments involved. And for the Lee-Ford 2 pyramidal fracture, Lee-Ford 2A, he said it will be pyramidal and nasal bone fracture. Lee-Ford 2 will be pyramidal and NOE fracture. For the Lee-Ford 3, which is craniofacial dysfunction, he said it will be craniofacial dysfunction along with nasal bone fracture, and craniofacial dysfunction along with NOE fracture. For the Marciani classification, Lee-Ford 2 and 3 will be combined and along with cranial base. So for 4A, he said supraorbital rim will be fractured. For 2B, he said anterior cranial fossa. The cranial fossa will be affected, the anterior one, and supraorbital rim will be fractured. For 4C, he said along with anterior cranial fossa, orbital wall will be fractured. Thank you and stay tuned for more.